Today is this young woman, 26-year-old. You see here, clear, huge, primarily lytic lesion, eccentrically placed over the metaphysis extending to the epiphysis. There is compromise of the epiphysis if you look at the MRI scans as well. So, and she's got a pathological fracture. This is a GCT. It's unfortunately not salvageable, as you can see here with her staging. Neurovascularly, she's intact. So we've had a detailed discussion amongst our team and her family and herself. So we're going to proceed on to a distal femur replacement here, because I think that's the only option we have available for salvage. So we're going to proceed with that. So clearly what you can see here is not good. Everything is involved, huge lesion going all the way proximally. So we're going to end up taking a significant, doing the resection significantly proximate to that, because this is a very aggressive lesion. The whole knee joint is destroyed. You see all this is squidgy. So hence the plan to just replace this part of the femur. But very aggressive lesion, and a poor girl would be in a lot of pain. So guys, as you can see, the situation much worse than what it appears on the radiographs, and even the MRI scan, all collapsed, nothing there. So what we're going to do is, yahan pe we can, if we just fraction this out of us, so we're templating where we're going to take this resection off, and we need significant margins, a wide resection of this. So what we put this here, isko seedha karna. So this is about 100. We can go 110, 120. I'm going to go around about 120. Around about here where we marked. फिर से mark करोगे इसको मेरे लिए?
Section दो जान.
इसको mark करेगा नीस मेरे लिए? Sir. This is where we're going to resect and then reassess. तो यहाँ पे. बस ठीक है. इसको अब यहाँ है. K-line. Okay. Well, no? Yeah. So now what we're doing is we aim to remove all of this in blocks, in one block. So I'm getting everything ready, doing the soft tissue dissection, taking the MCL off, as you can see here, which is very unusual for us to do that on a normal basis. So we're going to do this, and then we'll try to take this whole femur out smoothly.
बेल्ट तो कभी भी साफ हो जाएगा ना. एक मिनट हो गया.
स्क्विजी है ज़्यादा.
हाँ सर.
बोन के साथ.
हाँ सर. तो दूसरी साइड से जाके करते हैं.
So you can see we resected the bony part, which was all very mushy and involved, and posteriorly there was significant compromise. You can see here, this is the remnants of the tumor that we're going to meticulously take off as well. So we're in the posterior compartment here, and we've done an ample resection on this side. So you're going to see we're going to take all of this off, debride this, and then wash and then reevaluate and make sure that we've taken all the seedings and the soft tissues off. So you can see the soft tissues structures there. You can see the medial meniscus. The MCL is gone. This is the remnant of the superficial MCL. The LCL, this is the remnant of that. So we certainly need to do distal femur replacement. This is remnants of the medial genicular artery that's coming in, supplying the cruciate, which is gone as well. And posteriorly, this is the compartment, so the vessels will be right behind this fascial layer. See, we're in the process of preparing the tibia now. We've gotten rid of the tumor bed as well. Looks nice and clean here, as you can see here. We do a final check right before we do the primary preparations, but it looks very nice and clean. So the bed has been removed. The neurovascular structures, we've identified where they are and protected them. So I'm getting rid of all the soft tissues so we can start preparation of the tibia first. You can see here now we've prepared this bed. We've gone through this process. Tibia has been prepared. We're going to do the, first is start preparing the tibia to take the base plate with the stem. and I'll go through that with you. But the main thing is this. This is the whole crux of the operation. So you can see the vessel is just underneath here. You can see the vessel, feel the vessel here. So we're clear there. We've cleared all of this bed. You can see all that. So it's nice and clean now. There's no remnants of the tumor that we can appreciate. No remnants of the tumor. We've taken 120 millimeters of this, so 12 centimeters, and that inshallah we're going to incorporate that into our distal femur. And we've done a thorough curettage and clean of the femoral canal as well. So from this you can see the hamstrings at the back. You can see the quads on the side, medial periparietal approach. We have had to take a bit of the medial aspect of the cord, so part of the VMO region off as well, because I felt that was compromised. MCLs is off, LCL is off. Obviously you can see a little bit of the remnant of the lateral collateral ligament. This is the biceps coming in this way here, biceps femoris. And posterior capsule, the menisci have been removed. Behind this is the badness, the vessels.
जी आज हमने we have performed distal femur replacement for this young lady जिनकी उम्र तकरीबन 37 साल है. अब आपको resected part दिखाते हैं जो कि हमने end block remove किया था. ये distal femur का part है जो कि end block हमने remove किया है. हमने आपको एक्सरे के अंदर भी दिखाया था कि situation क्या है, लेकिन जब हम अंदर गए हैं तो look at the situation. इनका जो ये lateral condyle है, ये सारा का सारा दिखाया हुआ है, शायद आपको नज़र भी आ रहा है. ये cortical breach था यहाँ से. अगर हम आपको posteriorly जाके दिखाएं तो ये posteriorly पूरा का पूरा posterior compartment को इन्वॉल्व कर रहा था, और इसी तरह से posterior condyle जो है lateral का वो देखिएगा ये सारा कुछ गया हुआ है. Medial somehow survive किया हुआ है. The interesting thing about giant cell tumor is it never crosses the epiphyseal line. So joint cavity के अंदर ये breach नहीं किया था, लेकिन ये posteriorly और laterally जा रहा था. इसी तरह से हमने ये tibia का articular component remove किया है, और अब आपको दिखाएंगे किस तरह से हमने इनका DFA परफॉर्म किया है. So this is pretty much it.
Brush off. So basically now what we're doing is finishing off the tibial preparation. Sequentially reaming up. This is size 11. So we're just going to over ream by 1. 12 करते 10 की डाल देंगे. And we're going to use this 80 stem. 80 plus 70 जो tibial component होगा, that it ends up with whatever 150. It'll be 150. ठीक है. Stem component, a reasonable stem component here. As with other constrained implants, okay? Because of the constraints or forces that is going to be resulting after we do a constrained hinge implant. So we need a force propagation, transmission to the rest of the bone rather than just being the articular surfaces. Alright, now we're preparing the femur for a size to take a size 9. Both of these will be cemented components, and lengthwise is the same, and it's around 80. So we're going to just prime this up to take the implant. You see there we'll do this bit of a rasping sort of thing here. Exactly, it's like a filer. My favorite instrument in the orthopedic set is a filer. I call it the tax filer. And this is the filing remnants.
Motorized copy of filer.
The lazy man's filer. The tourniquet is off. We've cleaned everything else again. You can see this here now. How close we're operating. So we felt the vessel before. Now it's all very apparent. So all this tumor bed was right next to the vessel. It was right encompassing it almost. From this side, so we're great. It's great that we have managed to get rid of all the tumor, and the vessel we've confirmed that's intact. But this is how we operate. This is the importance of having a good plane, good teamwork, having a good exposure, and always being mindful, and never being too blasé or gung ho about this. If you go down slightly more, you're hitting the vessel here. 160 तूने के ये लंबा है ज़रा 70 की होगा ना. चलो थोड़ा ज़्यादा ही ठीक है. आ जाए भाई. तो ठीक है, अभी काफ़ी ज़्यादा कवरेज है और डीप है. is important है
जी वो ना किसी ऐसे बंदे ने
यार वैसे
design किया।
हो गया बहुत आ जाओ बहुत अच्छा है क्या साइज है यार ये लगता है कस्टम मेड साइज है इसके लिए ना So now we've done with this first procedure. So we're very pleased with this. You can see here, standard हमें femur से size मिलता है. We've got that. That's 70 millimeter, है ना, Chand? This is 60 and this is 50. Total 110. Where my plan was well above the intended that the pathological side and the fractures was here. So we've gone right above there. We're going to send it to the pathology lab to just to make sure that we've done the adequate resection. You can see the bed was repaired prior, as I showed you. The patella sits right on top here, so I'm very pleased with that. So there's no signal patella baha or alta. We've got a size 14 poly now. Moving to the tibia, we've got a size 2 tibia. We've got a stem of 80 and the tibial construction is 70, so 150 to here. And if you just look at this here, this really does look beautiful at the moment. So if you straighten this out here, full, nice and solid, and patella tracking is gorgeous there as well. So it's perfect. So I think that covers it. We're going to seal this up very nicely. We're going to get her an X-ray today, do some blood tests in the morning. We're going to get her fully weight bearing on this, and inshallah she'll have a good result. Just to mention that this is all being done at Mayo Hospital free of cost. So this was done through Baitul Mal. I'm very appreciative of Rich, Chand, who have organized through Baitul Mal to have this implant. This procedure is over 3.5 million if you do this in a private setup. Just this implant itself is kitna, Chand? 1.5 million or 1.4 million thereabouts. So thankful to the companies, also Mayo Hospital and the government for allowing us to do these procedures in this setting that we have. Hopefully she'll have an excellent outcome.